Morning, good afternoon, welcome everyone. We'll get started in just a few moments. In the meantime, please add in the chat where you're joining us from and who you are.
Sorry, come again.
Welcome everyone. Please add in the chat where you're joining us from and who you are. Please also make sure to select your audio and your language. To do so, please click on the globe icon at the bottom and it will take you to the English or French channel. On this slide, you can see the directions for the interpretation and how to select your language. Once you've selected your language, you can then mute the original audio. On this slide, again, you can see the interpretation instructions. It says to please be sure to select your language while you wait in both English and French. It also includes some graphics to show you where the globe icon is located, as well as how to select your language once you select the globe icon. We've also shared a few poll questions that we encourage you to respond to while we wait for others to join. The questions and answer choices are in both English and French in the poll, and the questions are also on the slide in both English and French. Question number 1. Different types of young people require different types of outreach and services, including young people living with disabilities. Agree or disagree? Number 2, it is not realistic and too expensive to provide tailored services to different types of young people at scale. Agree or disagree? Number 3, you should just plan for meeting all different young people's needs rather than doing a segmentation analysis. Agree or disagree? Please fill out the poll as we wait for others to join. And be sure to add in the chat who you are and where you're joining us from. Again, you can read the poll questions on the slide that is being displayed as well. We're going to go ahead and get started. Thank you again for joining us today. I want to welcome everyone again to today's session. My name is Brittany Getch, and I'm a program officer on the Knowledge Success Project at Johns Hopkins Center for Communication Programs. Knowledge Success is excited to be partnering with FP 2030 on this series. This is our 11th conversation in the Connecting Conversations series. And if you've missed previous conversations, you can watch the recordings on FP 2030's YouTube channel or read blog post recaps that include recording links on the Knowledge Success site and get up to speed. This conversation will last for approximately an hour, and we'll have an open Q&A discussion with our 3 speakers. It's being simultaneously interpreted into French, as I mentioned, and it's being recorded in both English and French. The recordings will be available in the coming days. Participants are muted throughout the duration of this conversation, but if you have questions for our speakers, please type them in the chat box as you follow along. My Knowledge Success and FP 2030 colleagues will be moderating the chat box and will get to as many questions as time allows. Just a little bit about this Connecting Conversations series in case you're joining us for the first time. Connecting Conversations is a series of discussions on adolescent and youth reproductive health, hosted by FP 2030 and Knowledge Success. Through the middle of this year, we'll be co-hosting these sessions every few weeks on a variety of topics. This is not your traditional webinar series. We're using a more conversational style, encouraging open dialogue, and allowing plenty of time for questions. The series has been divided into 5 themes. Our first one, which focused on a foundational understanding of adolescent development and health, started on July 15th and concluded on September 9th. Our second one, which started on November 4th and concluded on December 16th, focused on engaging critical influencers to improve young people's reproductive health. We're excited to continue this set of conversations with the discussion on how an adolescent responsive approach can meet the diverse needs of young people. Before we begin, I'd like to remind you to again select your language by clicking on the globe icon at the bottom and choosing either English or French. You can then mute the original audio. First, I'm pleased to introduce our moderator for today's session, Kate Plord. Kate Plord is a technical advisor at FHI 360, where her work focuses on gender and adolescent and youth health and development. She is a member of the Knowledge Success team. Welcome, Kate. Over to you.
Thank you, Brittany, and good morning, good afternoon, good evening to everyone on the line. It is my pleasure to introduce our conversationalists for today's session. First, we have Dr. Sani Aliu. He is the Niger Country Director at Pathfinder International. He's a medical doctor with more than 30 years of experience in public health, with a focus on maternal and child health. He spent half of this professional time in Niger, his native country, and the other half in several other countries of East, Central, and West Africa. Dr. Sani spends most of his free time with his family when he's not farming. Marta Pierzadeh is a Senior Technical Advisor for Adolescent and Youth Sexual and Reproductive Health and Rights at Pathfinder. She has over 20 years of experience with technical expertise in adolescent and youth programming, meaningful youth engagement, community-based family planning, reproductive health, HIV, maternal and infant health, and many other things. Marta has an MPH in health behavior and health education from the UNC Gilling School of Global Public Health. And finally, we have Ramchandra Gaire, who is the General Secretary of the Blind Youth Association in Nepal. He is a youth advocate for persons with disabilities. Mr. Gaire has been working for the promotion of sexual and reproductive health since 2015 and is a leader in the inclusion of persons with disabilities in sexual and reproductive health and rights. His organization has been collaborating with many other organizations, like-minded organizations, to increase the understanding of sexual and reproductive health and service providers, as well as to develop the capacity of young people with disabilities. He has also been engaged as an independent consultant to design and develop accessible and inclusive programs. He has a master's and graduate degree in sociology. As we transition into the discussion, as Brittany noted, we will do our best to answer all of the questions that are posed in the chat, but please know that we will not have time potentially to answer all of them. Also, please do not forget to select your language using the globe icon on the bottom of your screen. So we all know that young people have multiple intersecting identities related to their age, marital status, educational attainment, geographic location, economic status, religion, gender, parenthood, ethnicity, physical traits, etc. These intersecting identities impact young people's sexual and reproductive health behaviors, as well as their access to services. Today's conversation will focus on how a variety of services within a health system can better meet the diverse needs of young people. One common approach to understanding the various groups of youth that are most in need and to identifying the kinds of services a system should offer to meet those needs is something called segmentation analysis. For those of us who are less familiar with this idea, I pose this question to our panelists. Can you explain what a segmentation analysis is and why it's important?
Hi, this is, oh, go ahead.
Mrs. Sani, I just want to say that actually segmentation is an approach of dividing population or a group of people into subgroups based on criteria that you identified before. It could be demographic, it could be behavioral, etc. And you make that grouping based on that criteria. And as said, it could be demographic, like age or matrimonial status, married or not married, etc. Thank you.
Thank you, Dr. Sani. Marta, would you like to add to that?
Sure. I think what Dr. Sani said is exactly right. And in global health and public health and across markets, you know, we've been segmenting for years, for decades, really. But oftentimes we've been segmenting at a more basic level than we're moving toward now. Really, in the past, historically, in global health, we segmented based on demographics, as Dr. Sani mentioned, maybe, you know, maybe getting to some nuance of marital status or parity, religion, but we weren't as focused on segmentation as we have become more advanced in recent years. So, you know, overall, at Pathfinder, we're doing quite a bit of segmentation with several of our projects, and we're really focused on getting a better understanding of the different subgroups of a certain population. Today, we'll talk some about youth and providers, I think, but going beyond the demographic factors and focusing more on attitudinal and behavioral characteristics. And so that's really what makes the type of segmentation analysis that we're talking about today a bit nuanced compared to the historical segmentation along demographics.
Thank you. And it's also very good to learn that what Pathfinders is doing in terms of segmentation analysis. And talking about our experience working with young persons with disabilities, segmentation analysis is particularly important to understand the different accessibility issues, because what fits to the one type of disability not necessarily accessible to another one. That's why generally, as a conventional way, people just take the report or the demographic representation of the people with the disability, but that is very much, you know, kind of, you know, gray area to get the specific information or specific nature of the particular groups, and that is really problematic to design the intervention. So segmentation analysis or that kind of, you know, design is very much important when it comes to the accessibility and the universal design of the services, particularly for the young persons with the disability. So it's a kind of, you know, important, but not done so much in terms of disability.
Thank you, Ram. That's a very important point. And I really like the way that you said, you know, we can't design one approach for young people with disabilities and expect that to be accessible for all youth with disabilities. It's the same at the same level. We can't design one approach for youth and expect it to be accessible for all youth, no matter what their various intersecting identities are. And, you know, typically those of us who may be familiar with segmentation analysis and programming for adolescents and youth, typically we think about segmentation analysis related to young people. So what are the various populations of young people in a specific area? What are their needs? But segmentation analysis can also be important for understanding population groups other than youth within the context of advancing adolescent and youth sexual and reproductive health. For example, Pathfinder International and Camber Collective worked together in the past to understand the different subgroups and segments of healthcare providers. Marta and Dr. Sani, perhaps you can share with us why the project conducted segmentation analysis of healthcare providers in order to advance adolescent health, and what was learned from this initiative, and how might these learnings be applied for other adolescent sexual and reproductive health programs globally.
Sure, I'll get started here. As I mentioned, at Pathfinder, we have 4 projects that are really have a strong segmentation analysis component, and they're quite different and in different contexts, but the one that you're speaking of is called the Beyond Bias Project, which is in 3 countries, in Burkina Faso, Pakistan, and Tanzania. And you're right, and the other 3 projects, we actually were segmenting along youth characteristics, but as I'm sure many of you know, that the manifestations of provider bias can be very difficult to measure, and we're learning a lot about the different types of provider bias, and as we learn more, we learn how difficult they are to address as well. And so, as Kate mentioned, with our partner Camber Collective, we worked, in these 3 countries and with in-country partners to develop and implement a survey of providers to test the key drivers of provider bias. And, as I mentioned earlier, the focus was less on demographics of the providers and more on attitudinal and behavioral characteristics, which can be a very powerful tool for understanding intent to change behaviors. So what we've really learned through this work of segmenting providers is that these characteristics, the segmentation can really provide some nuance and help us to figure out how to make decisions for prioritization of interventions and which providers make the most sense to target. And what we've been able to learn from we ended up coming up with identifying 6 segments of providers across these 3 countries. And what we were able to learn from these 6 segments was who we should focus on and what type of programming might be most successful. So while we can't say that we could scale this to all countries, that the 6 segments would go across all countries, we do feel that because we've done this across 3 different countries in 3 different contexts, that we have quite a bit, to share with the AYRH community, as well as, some real lessons learned on provider bias and the nuances of bias.
Thanks, Marta. That's great. Dr. Sani, please go ahead.
Yes, I would like to give the example of Niger, where we took advantage of the Ministry of Health program of doing a segmentation at a national level, where they come with 5 segments based on attitude, knowledge, and behavior of women to family planning. And so we had a project targeting married adolescent. And for that project to increase the demand for family planning, you use that segmentation results, and we integrated that segmentation into the health facilities. And what we learned is that, having that segmentation improves the quality of the counseling when you have that interaction between the provider and the clients, knowing before starting the actual counseling, when the provider is aware about which segment is coming the clients, he or she can have more, focused and tailored discussion and the message, instead of providing general message or discussion with the client. That could become more interactive, and that is something that we learned from that program as we implemented it.
Thank you, Dr. Sani. And as we're thinking about learning from tailoring programs to various segments of adolescents and youth and providers and other influencers, I'm wondering, when we think about how to better understand and identify the groups of youth that a program should be addressing, who are we unintentionally excluding with our activities, and what do people get wrong about meeting the diverse needs of young people?
Okay, if I may jump here, thank you. It's a very, very important issue that you have raised, because obviously there are certain groups. Whenever we design the programs, as we said, like one size doesn't fit to all. Unintentionally, certain groups are left out from our design programs, and sometimes the sectoral tailor-made is not. I don't say not possible, but people do not think that much. Like, whenever we do the tailor-made for a certain area or certain segment, but within that, the intersectionality is something that we should not forget about. I just want to share one example from our project under FE 2020 that we were doing, because we target our training program to the adolescents and youth age from 15 to 25, and they were mostly the high school graduates. So we had a certain level of mindset that this level of educated teenagers or adolescents and youth might have this level X number level of understanding, but when we reach to the deaf community, then we realize the knowledge that we were projecting before the training was very, very low. That is because there's a very less medium to communicate about the SRHR and CSE component among them. And that is not because nobody taught them, but that is because the availability of the words in sign language is very, very less. So that sort of things sometimes, because, and sometimes we also, our programs, we think in a general context, in a broader context, which is very important. But the tiny things that may not be represent in a data, but equally important. So that's kind of comprehensiveness, that sort of intersectionality things need to be very much well understood, and that is what somehow lacking. And when it comes to the excluded community or the people, and since I represent the disability community, so I feel that, or we feel that this is the community who are not intentionally ignored, but due to lack of those tailor-made approach and accessibility features, even though the program tried to target, or the providers wanted to give the better service, everyone says like, yes, we want to do this. What is, many people know, but then the how part is very much missing. So so I would say like it's a simple, looks simple things may not be major into the big number, but the accessibility or the detailed analysis, that part is very much missing. And and sometimes the key barrier might be kind of fear or lack of interaction between those community and the designers or we providers, because sometimes we think that the specific intervention when it comes to the disability, it may think that the additional money, additional resources, or additional skills, but general case, in most of the cases, the accessibility or these tailor-made approaches are not so much over costly, I would say. I'll stop here, but I'll love to reconnect later on, Kit, please.
Can I say a few words here? I mean, another
Yes.
example from Pathfinder, where we implemented a project targeting students at the university level through the Evidence to Action project, a global USAID project. As we know that the students are sometimes excluded from health programming because it is a population that is stable, changing. Your denominator cannot follow and show the change you are making within that community, because it keeps changing from year to year. So we had that approach of integrating sexual and reproductive health into the university. And what we found is that despite being at that level of education, the big majority of students are not really aware about what is sexual and reproductive health, what are the rights, what can they do to prevent infection, or taking care about any issue related to sexual and reproductive health. And that project also demonstrated that a group of population can not only benefit directly from the implementation of such program, but also being a leader. And the program is called University Leadership for Change. And the student, after working with the project, became also a leader in their own community when they go on leave. And so through peer approach, we developed a link between youth at the university and also youth at the community level. And so that is something, many programs have been missing as an opportunity of changing behavior and increasing the access to sexual and reproductive health to youth. Thank you.
Thank you, Dr. Sani. And Ram, these two examples that you have provided, I think highlight the important point about making assumptions at baseline about what a certain population might have had access to in the past, and where you're starting from. And I think that is a really interesting point. I wanted to read also just one comment that came in the chat box from Liz, saying that it's so interesting about the lack of language to discuss a topic, that she's heard similar things about the lack of mental health terminology in some languages, which can make conversations and developing interventions that are integrating mental health also limiting, and just the importance of language. And Ram, building upon your point about the approaches to tailor to different populations and the how, I wondered if all of you might be able to provide some examples of successful strategies or approaches that you can use to really understand the needs of the various segments of the population. For example, Ram, can you describe the strategies that your organization is implementing to promote disability inclusive sexual and reproductive health and family planning?
Sure, thank you. Yes, I just like to share one example. When we were conducting training in one of the remote part of the country in far west Nepal, then we visited one of the deaf school. It was a primary school where around 80 to 90 deaf students are studying currently, and majority of them are now around 12 to 16 years, though they are in primary school and they are deaf. And we asked the teacher, school teacher there, and how do they manage their menstrual hygiene and sanitary pad? And they say that the government is providing the sanitary pad for free of cost to the school students, but only from grade 6. That is kind of blanket approach. But those deaf girls who are adolescents, and they are only up to the grade 5, but their menstruation has already started when they are 12 or 13. So then those students were not able to access that sanitary pad, which is provided by the government for free of cost. For that, they need to upgrade up to the grade 6. Now, I think these kind of examples, when we design these kind of bigger interventions with the blanket approach, that is very much excluding. So and also another example, as mental health, Liz commented on the chat box. So yes, of course, there are very less languages to communicate about sexual and reproductive health rights for people with mental disability, intellectual disability, or autism. So, and also for people with severe disability and deaf-blind, because one of the things that our association tried to do in these few years of our time is early intervention is very, very important. What? Yes. So early intervention is particularly important when it comes to the disability inclusive SRHR program designs and service intervention. Let me give you one example. Everybody knows, how to use the sanitary pad by looking at the pictures or the posters or video documentaries. But how to teach the blind girl who is totally blind, and how to teach her to use the sanitary pad, and that intervention needs certain touch and the certain feel through the hand. So for that, we can't wait until she gets her first period to teach her how to use sanitary pad. That intervention would be too late. So one of the area that we are focusing is before those girls get into their puberty, we already need to teach them those kind of skills so that when they get their first period, then they should be able to use those skills. This looks very simple, teaching a blind girl how to use sanitary pad, but we have a number of cases where the blind girls are using sanitary pad just the opposite way. As a result, their skin is very much damaged. So these kind of things, and also to teach the child with autism in their young age how to manage their bodily changes, how to manage their sexual desires, because these things are very much natural, and the parents, the teachers, and the care providers are also unaware on how to do that when they get little bit old age. So it's very, 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 very lack of skills and lack of that kind of attention, and the discourse, we are also discussing about these kind of things. So these things are very much in need for those people. People are nowadays realizing these things need to be delivered for them. One of the realization of these needs is today's webinar also. So thanks for that. And what we are doing is we are trying to gather those organizations and people from those sector of disability to teach these kind of things in earlier stage, so that the early intervention, early detection, and early training before they get into these age is very important. And also there are other design that we are doing when we don't have a certain skills to communicate with the deaf people. What we have done is we invite the sign language interpreters, and now we are training the sign language interpreters to develop the certain sign language to communicate about the SRHR issues. For example, in Nepal, there is no word in sign language to communicate about LGBTIQ. And also there's no words to communicate about the contraceptive methods except condom. So these are the things that we are trying to develop, because one side doesn't fit to all. I'll stop here.
Thank you, Ram. These are very rich and interesting, insightful examples. When we think about the tools that are available to us as well, in terms of designing services that are inclusive, that also meet the needs of various segments of young people, I wonder what tools and approaches are available. And I know Marta and Dr. Sani, at Pathfinder, you have a tool called Thinking Outside of the Separate Space, which is a decision-making tool for designing youth-friendly services. Can you tell us a bit more about this tool and how it can be used by the adolescent, youth, sexual and reproductive health community to support a segmented approach to service delivery?
Sure, thanks, Kate. Yeah, I love this tool. I'm sure some of you may be familiar with it. I'll be happy to share the link later or put it in the chat box in a bit. But the tool you're talking about was developed by Pathfinder. through our evidence to action project. And again, it's called Thinking Outside a Separate Space. We call it the TOSS tool. And it is a decision-making tool to guide program designers in selecting and adapting appropriate youth-friendly service delivery models. And it's very contextual, based on country context, target population, desired behavioral and health outcomes, what SRH services you may have available, and other factors. And so I won't go too deep into it, but basically what the tool does is, allows the decision makers to look beyond the most common approach, which is using a separate space, or a separate clinic to reach young people, which of course we've learned is not always the most appropriate. It sometimes may be more costly or difficult to sustain. So within this tool, there are 7 different models and examples that program designers can walk through a 7-step process and determine which of these 7 models or which combination of these models may best respond to the needs of their program. And then they can go through some steps of considering the epidemiology and desired health comes for the youth, and which subpopulations of adolescents and young people they may be trying to reach, and then really use the tool to look at their own project, what resources they have, their needs, what they know about youth in their context, and then really the feasibility within their current system, whether it be private, public, or a combination, to align their selected model to the context. So, and then at the end, once they go through this whole process and select which model or combination might be most appropriate, there's an entire step to help plan for the scale up of the selected model or models based on the WHO and expand that literature. So I would encourage all of you to look at it. I will certainly share the link, but it is a really exciting tool to be able to go step by step, considering, as we've been talking about this whole time, the nuances in your population, in your resources, what you're trying to reach, and make a decision that works best for your program.
And Marta, I'm glad you mentioned scale, because we're getting a lot of questions and comments in the chat box about, in support of this idea of segmentation, recognition that this is, critical for youth. But we're getting questions like, can this approach, we're talking about this whole module is on adolescent responsive systems. Can this approach be implemented at scale by an entire system? Is tailoring services more costly? How do you account for this in trying to reach diverse groups? And then finally, how do you take into account all of the various intersecting needs of young people, those who are in school, and are married, out of school, all of these things that we're talking about? So it sounds like folks are thinking, wow, this is great, but how can we do this at scale? I'd love to hear thoughts from all of you.
I can jump in really quickly, but I want to make sure to give Dr. Sani and Ram an opportunity. But, this is a really interesting question, Kate, that we often discuss and think about. In some ways, scale and segmentation are 2 opposing forces. In a way, you might think that segmentation is really trying to find the nuance and it's going deep, whereas scale is trying to reach the masses. So it is something that we all have to work toward, is better understanding how we can use segmentation at scale. You have to, and the reason I mention that is because, I think there are lots of approaches that become hot, or they're the buzzword of the moment. And I think segmentation is very popular right now, but it's really important to figure out the utility of the segmentation before you do it, if it's really the right approach for you. And if segmentation is done at a broad scale, say, for example, across countries, then you might be able to scale it. But if you're really looking, deep within a certain community, it could be quite difficult to scale. So as I think I mentioned earlier, you know, with 2 of the 4 projects where we've done segmentation analysis, we've done it across 3 different countries in 3 different contexts to try to identify solutions that could be scaled globally. So we selected 3 countries from very different regions. For example, in Beyond Bias, we had East Africa, West Africa, and South Asia in order to gain insight that could be implemented at scale. I think, you know, Dr. Sani could tell you a little bit about the impact project probably, and the tool that is done, you know, perhaps at scale in Niger, because it's across 1 country. So it really depends on how you define scale, and if you're thinking of global scale or, you know, in country scale, because obviously, you know, so many variables differ from country to country and context to context. So it's a really interesting question. I think we'll all continue to grapple with for a bit.
Yeah, thank you very much. Actually, as I said, in Nigeria, we had that experience of having the segmentation at a national level, a broad one, which was used by the government to develop its national communication strategy, you know, to also at that level of messaging, tailor the message according to the segment that are common to the country. But as she said, as Martha said, at the local level, health facility level, having the segmentation is a way of improving the quality of the counseling, as I said. So again, because of the success that it's having, we have seen that the Minister of Health is very much interested and is trying to mobilize more resources for scaling up that approach throughout the country. So it is very important to make sure that I mean, the partners from the Minister of Health, the government, also owning the approach and the process. So as when you introduce it, because of the staff turnover, it cannot be, I mean, limited in the time. So that's why also a reason for making that scaling up, because then you have almost all service providers are trained, and you don't have I mean, a situation where someone have been trained and use the segmentation in the day-to-day activities, and then you replace it by another person who doesn't have that capacity. So it depends on the context, and I'm sure that it's possible to scale it up. And actually, Pathfinder in Niger is trying to integrate it into its program throughout the country, the impact program. Thank you.
If I may jump, with very little year of experience working in this sector, what I think is when we see the SDG principle, leave no one behind, I think some sort of segmented interventions or that kind of analysis is very important. But again, the scale is equally important. That's why based on our approach and based on what we have done is we need to do these kind of segmented kind of support or these kind of intervention in integrated approach. When we design specific segmented programs, one here, one there, one there, one there, then obviously it's very much challenging to scale up. But that's why the tailor-made within the broader system, the sectoral tailor-made or sectoral segmentation can be included, and that is also the principle of inclusion. And that will, I think, in my understanding, also contribute to the scale, as well as it will not left the certain segmented people.
Thank you all. These are really great insights. I'm going to switch gears a little bit and move over to a question that we received in the chat about the impact of COVID-19 on and the in-person programming restrictions on this type of approach. Have these restrictions made it harder in your experience to reach specific segments of young people? Have your programs identified any solutions to maintaining tailored and intentional approaches during this time? And have you found anything that has been extremely effective? And Ram, you are still muted.
Okay, am I audible now? Yeah. Okay.
Yes, please go ahead.
Okay, thank you. Yes, COVID pandemic has hardly hit it to everyone, but mostly to the people with disability, because these are the people, mostly the adolescents or youth. They used to live in institutional setups with their friends and the care providers. But due to the lockdown and pandemic, most of the institutions were shut down and has to go back to their community, where the parents lack skills on how to interact with their children, and the children themselves, due to the restricted mobility and restricted communication, and their support systems were very much collapsed, because most of they were from the remote area, and uh, their friends were missing, their schools were missing, their care provider support systems were lapses. That's why it was very challenging, and we designed our approaches in a different way. Like the technology for blind people was really helpful, and we tried to reach through the Zoom and this kind of virtual platform, where we first give them the skills on how to use the technology, and then we provided certain skills on how to access that technology. Then only through that technology training, then we were able to then we were only able to provide those kind of trainings to them. But it is a little bit challenging for the deaf community to interact through the virtual platform. So we developed various infographics, digital content that are more accessible, not only in terms of language accessibility, but also in terms of alternative formats. So these were developed and circular by utilizing the social media. I'll stop here.
Thank you, Ram. Marta, would you like to add to that?
I can really quickly. I think one of our experiences with COVID-19 that has changed a bit about the way that we've had to adapt has been an example in Pakistan with our Naya Kadam project. And as I'm sure many of us on this call know, that women and girls have really bear the brunt of COVID-19 secondary impacts. And so within this project, although not a youth specific response, we have found that the female health workers have really been affected tremendously by COVID, and with mobility restrictions and increased infection and transmission without PPE and such. And so, it really forced us to look at gender sensitive responses in this case and many others, as well as, how we can integrate those critical SRHR content into public health messaging around COVID-19 as well, because as Ram said, we were doing most of this virtually, with having to adapt new job aids, whether it's through Zoom or whether it's through, non-contact approaches, to be able to enhance these health workers, communities, ability to respond to gender-based violence and make appropriate referrals. So, I think that obviously COVID is affecting all aspects of society and all of the communities, but with 70% of frontline health workers in many countries, and in Pakistan for sure, being women, we've had to really segment along those lines, if you will, and respond to the unique needs of both gender, COVID-19, age, you know, and all of those different segments of the population to ensure that women and girls and communities are safe during this time.
Thank you, both Marta and Ram. These are excellent examples. And I want to thank all of the panelists today for sharing your programmatic experiences, your wonderful insights, and really helping us better understand how we can focus a variety of services within a health system to meet the diverse needs of adolescents and youth. And just a reminder to all that this session was recorded. There will be a recap blog on knowledge success. There were resources that were posted in the chat box. Those can also be shared on the blog. So please, this is not the last time you will hear this conversation. It will be continuously available to you. And I will turn it over now to Brittany to close us out.
Great. Thank you, Kate. Thank you, speakers, for this great conversation. And we hope that you'll join us for the next session. Our next session will be on April 8th at 7 a.m. EDT, Eastern Daylight Time. And we'll look at what does it look like to implement an adolescent responsive approach. So we've talked about how this transition has happened to an adolescent responsive approach. We've looked at today how to meet the diverse needs of young people. So we'll really look at in our next session how to implement it and how to go about operationalizing it. So again, that's on April 8th. We hope you'll join us at 7 a.m. Eastern Daylight Time. And we also hope that you'll follow FP 2030 and Knowledge Success at the handles you see below to continue the conversation. Thank you all again for joining us today, and thank you, speakers, for such a great and rich discussion. Have a great day, evening, and night. Bye, everyone.
Thank
Thank
you
you,
very much.
everyone.
Bye.